Welcome. This session is a practical guide to evaluating prosthetic heart valves using ultrasound, primarily transthoracic, and transoesophageal echocardiography with Doppler. We will focus on the questions you need to answer at the bedside. Is the valve opening and closing normally? Are gradients appropriate for the prosthesis and the patient's flow state? And is any regurgitation present, particularly paravalvular leak? Echocardiographic assessment of prosthetic heart valves is one of the most challenging areas of cardiac imaging. Prostheses have intrinsic acoustic properties that generate artifacts such as reverberations and acoustic shadowing, which can easily be mistaken for pathology. In addition, all prosthetic valves behave as a fixed obstruction to flow, producing normal pressure gradients and a degree of physiological regurgitation. These features mean that abnormal appearances on echo are not always synonymous with valve dysfunction. For the non-cardiologist intensivist, prosthetic valve evaluation therefore requires caution, careful integration of flow physiology, valve design, and clinical context, and a low threshold for specialist input. In this module, we will define what normal looks like for the main prosthetic valve types. We will link the valve design, labeled size, and flow state to the expected Doppler profile. You will see how to optimize imaging with transthoracic echo and when transoesophageal echo adds decisive value. We will then focus on the key Doppler measurements for prosthetic aortic valves, and we will do the same for prosthetic mitral valves. After that, we will tackle high gradients with a structured differential, high flow, patient prosthesis mismatch, or obstruction. We will finish with regurgitation, including how to identify paravalvular leak, and we will review the main complications you must not miss. Start by identifying the valve type, because normal depends on the design. First are biological valves. These include surgical bioprostheses, which may be stented or stentless. Stented valves have a rigid frame and a sewing ring, which can slightly reduce the effective orifice. Stentless valves have no supporting frame and often provide a larger functional orifice for a given annulus. Biological options also include homografts, which are donor human valves, and autografts in the Ross procedure. Next are transcatheter valves, most commonly used in the aortic position. They can be balloon expandable or self-expanding, and they may be implanted as valve-in-valve inside a failing surgical bioprosthesis. Finally, mechanical valves include bileaflet, single tilting disc, and caged ball designs. Each mechanical design has characteristic flow patterns and often small physiological leakage jets. So, before you label a gradient as abnormal, match your Doppler findings to the specific valve and its size. This slide illustrates the wide variety of prosthetic heart valves encountered in clinical practice. Mechanical valves are highly durable but strongly echogenic and require lifelong anticoagulation. Surgical bioprosthetic valves are tissue-based, with more physiological flow but limited long-term durability. Transcatheter valves, implanted by TAVI or TAVR, are stented bioprostheses with distinct imaging characteristics. Recognizing valve type and design is a critical first step, as it directly influences normal Doppler findings, artifacts, and the interpretation of potential complications. Bioprosthetic valves are tissue-based and may resemble native valves on echocardiography, with dysfunction developing gradually through leaflet thickening, calcification, or tearing. Mechanical valves have more distinctive acoustic features, often higher physiological gradients and visible occluders, particularly in the mitral position. They also produce normal low-volume regurgitation jets, which should not be mistaken for pathological regurgitation. Prosthetic valves do not behave like native valves. Their Doppler profile depends on the valve design and on the size that was implanted. The labeled size can be misleading because it does not always reflect the true internal diameter. So you must match your measurements to reference values for the exact valve model and size. Also remember that some echo findings are physiological for a specific prosthesis. Small normal regurgitant jets are common with mechanical valves and do not automatically indicate dysfunction. Finally, the most powerful comparator is the patient's own baseline post-operative echocardiogram. Before you measure anything, anchor the study in the clinical context. Heart rate, rhythm, and blood pressure can completely change gradients. Next, confirm what valve is in place, where it sits, and what size it is. Then image the prosthesis carefully to check motion, seating, and any abnormal masses. After that, move to Doppler and sample from multiple windows to avoid underestimating velocity. Remember that Doppler numbers only make sense when you also assess chamber response. Do not forget the rest of the valves, because concomitant disease may drive symptoms. Estimate pulmonary pressures when the tricuspid regurgitation envelope is reliable. Finally, always compare with prior studies, because change over time is often the key diagnostic clue. When you image a prosthetic valve, your first comparator is the baseline post-operative study. The overall approach is similar to native valves, but prostheses create much more artifact. Start by confirming leaflet or occluder motion and then inspect the sewing ring and surrounding structures. Actively look for restricted motion, abnormal rocking, or any new masses. Remember that reverberation and acoustic shadowing are expected, and they can obscure key areas. That is why you should sweep through multiple views and optimize gain and depth. Keep in mind that each valve design generates characteristic flow patterns that shape the Doppler profile. Finally, a small number of transient microbubbles can be a normal finding with mechanical valves, particularly in the left ventricle with a mechanical mitral prosthesis. These usually relate to cavitation and dissolved gas coming out of solution during closure, often rich in carbon dioxide. The key is to recognize the pattern so you do not mistake a normal finding for pathology. This slide illustrates how the position of a mechanical prosthetic valve influences echocardiographic appearance and the color Doppler regurgitant jet. For aortic prostheses, the regurgitant jet may be better visualized in parasternal long axis or apical two-chamber views, depending on valve orientation and acoustic shadowing. For mitral prostheses, jet direction and visibility vary between parasternal and apical four-chamber views, with reverberation and shadowing often limiting assessment. This highlights the need to image prosthetic valves from multiple windows and not rely on a single view when assessing regurgitation. Toe is ideal for defining prosthetic valve morphology, especially in the mitral position. First, recognize what is normal for the valve design you are looking at. Mechanical valves create strong shadowing and reverberation, so the sewing ring is bright and parts of the valve may be obscured. When possible, confirm occluder motion and remember that small physiological leakage jets are expected. Bioprosthetic valves should show thin, mobile leaflets with good coaptation. Stented valves have clear landmarks, while stentless valves look more native and can be harder to orientate. With transcatheter valves, identify the frame and actively look for paravalvular regurgitation. When you inspect a prosthetic valve, start with motion. Are the leaflets or occluders opening fully and closing cleanly? Next, scan for abnormal echodensities because thrombus, pannus, vegetation, or degeneration can all restrict motion. Then focus on the sewing ring and its attachment to the annulus. Any separation or abnormal rocking should raise concern for dehiscence and possible paravalvular leak. If TTE is limited by artifact, TOE is often the fastest way to confirm the mechanism. For a prosthetic aortic valve, start with a well-aligned continuous Doppler signal. Record peak velocity and mean gradient, but interpret them in the context of heart rate and flow. Then look at the CW jet contour, because a rounded, late peaking profile supports obstruction. Measure acceleration time and the AT-ET ratio to add another flow-independent clue. Next, use the continuity equation to estimate effective orifice area when LVOT measurements are reliable. If LVOT measurement is uncertain, the dimensionless index or Doppler velocity index is often more robust. Finally, always assess aortic regurgitation and actively search for paravalvular leak. A complete Doppler dataset helps you distinguish high flow and patient prosthesis, mismatch from true prosthetic obstruction. Start with a well-aligned continuous wave. Doppler trace across the prosthesis. Use multiple windows because a small angle error will underestimate velocity. Record the peak velocity and the mean gradient, but do not interpret them in isolation. As a rule of thumb, a Vmax below 3 meters per second and a mean gradient below 20 millimeters of mercury are usually reassuring. Values in the 3 to 4 meter per second range, or mean gradients between 20 and 35, should trigger a structured check of flow state and valve size. A Vmax above 4 or a mean gradient above 35 supports significant obstruction, but only after you exclude high output states and patient prosthesis mismatch. Remember that the simplified Bernoulli equation gives the peak instantaneous gradient as 4 times velocity squared. Finally, always compare with the patient's baseline post-operative study, because change over time is often the most important clue. When gradients are raised, the CW Doppler shape gives you extra information beyond the numbers. A normally functioning prosthesis usually has a triangular, early peaking envelope and a short acceleration time. With obstruction, the contour becomes rounded and the peak shifts later in systole. Measure acceleration time on a clean envelope because an AT above 100 milliseconds is suggestive of obstruction. Then index it to ejection time because an AT to ET ratio above 0.40 supports obstruction. Use these features to separate high flow or mismatch from true prosthetic obstruction and always compare with baseline. Effective orifice area is the functional opening the blood actually uses, not the labeled valve size. That is why two prostheses with the same labeled diameter can have different EOAs and different gradients. We calculate EOA using the continuity equation, LVOT area times LVOT VTI divided by the prosthetic aortic VTI. The critical step is measuring the LVOT diameter accurately because small errors are squared and can change EOA substantially. If the LVOT measurement is uncertain, do not force an EOA. Use the Doppler velocity index and, above all, compare with the baseline post-operative study. The effective orifice area, or EOA, reflects the functional opening of the prosthetic aortic valve. It is calculated using the continuity equation as stroke volume divided by the VTI through the prosthesis. Stroke volume is derived from the LVOT cross-sectional area multiplied by the LVOT VTI measured with pulsed wave Doppler, while the prosthetic VTI is obtained using continuous wave Doppler across the valve. Accurate LVOT diameter measurement is critical, as small errors are squared. The pulsed wave sample volume should be positioned just proximal to the prosthesis, in laminar flow, avoiding the acceleration zone. The highest and best aligned continuous wave VTI should always be traced. As a practical guide, an EOA greater than 1.2 square centimeters is usually normal. Values between 0.8 and 1.2 square centimeters suggest borderline or moderate obstruction, and an EOA below 0.8 square centimeters is consistent with significant prosthetic obstruction. These thresholds are valve size dependent and should always be interpreted in the clinical context and against prior baseline studies. Here, we're comparing the correct and incorrect way to measure LVOT TVI. In the top images, the PW sample volume is placed in laminar LVOT flow, just proximal to the prosthesis and before the flow acceleration zone, giving an accurate TVI of 27 centimeters. In the bottom images, the sample volume is placed within the acceleration zone, which falsely increases the measured TVI to 38 centimeters. This error can distort derived indices, so careful sample placement is essential. Measure the LVOT diameter in parasternal long axis in mid-systole, inner edge to inner edge. For surgical aortic prostheses, measure just below the sewing ring. For TAVI, measure at the ventricular end of the stent frame and keep it matched to your pulsed wave sample site. If the diameter and VTI are taken at different levels, your continuity calculation becomes unreliable. And because the diameter is squared, a small error can make a big difference to EOA. The Doppler velocity index, or DVI, is a quick way to judge prosthetic aortic valve performance. It is the ratio of LVOT VTI on pulsed wave Doppler to the prosthetic aortic VTI on continuous wave Doppler. Because it is a ratio, it reduces the impact of LVOT diameter error and avoids calculating stroke volume. A DVI below 0.25 strongly supports significant prosthetic obstruction. Borderline values between 0.25 and 30 need careful context, especially flow state and valve size. To measure it correctly, keep the LVOT sample just proximal to the valve and away from the acceleration zone. Then obtain the highest continuous wave signal through the prosthesis from multiple windows. This slide summarizes the Doppler features that point towards significant prosthetic aortic obstruction. No single number is diagnostic, so look for a consistent pattern across parameters. A peak velocity of 4 meters per second or more, or a mean gradient above 35, is a strong warning signal. Support that with a low EOA, a DVI below 0.25, and a prolonged acceleration time. Then check the CW envelope because a rounded late peaking contour fits obstruction. Finally, sanity check everything against flow state, valve size, and the baseline post-operative study. Once you have measured Vmax, mean gradient, EOA, and DVI, the next step is benchmarking. Normal values are not universal. They vary with valve design and labeled size, so you must use valve-specific reference tables. This table provides typical Doppler values for common prosthetic aortic valves across sizes. Use it to decide whether your findings are expected, borderline, or clearly abnormal. For a prosthetic mitral valve, gradients are highly heart rate and flow dependent, so start with a continuous wave, Doppler envelope, and always record the heart rate. Measure peak velocity and, more importantly, the mean gradient across the prosthesis. Next, estimate effective orifice area using continuity, with stroke volume from the LVOT and VTI through the mitral prosthesis. If LVOT diameter is unreliable, use the Doppler velocity index, which is the ratio of mitral prosthesis VTI to LVOT VTI. Finally, pressure half-time can support your interpretation, but it should never be used in isolation. For a prosthetic mitral valve, velocities and gradients are highly dependent on heart rate and flow. So start with a well-aligned continuous wave, Doppler trace and record the heart rate. As a rule of thumb, a peak E velocity below about 1.9 meters per second and a mean gradient of 5 or less are usually reassuring. A peak E of 2.5 or more, or a mean gradient above 10, strongly suggests significant obstruction. Before you label it stenosis, check for tachycardia, anemia, high output states, and significant regurgitation, which can all raise gradients. Finally, compare with valve-specific reference values and the patient's baseline post-operative study. For prosthetic mitral valves, EOA is best estimated using the continuity equation. We take stroke volume from the LVOT and divide it by the VTI through the mitral prosthesis. That gives EOA as LVOT area times LVOT VTI, divided by mitral prosthesis VTI. Accuracy depends on measuring LVOT diameter and PWVTI at the same level in laminar flow. Then you need a clean, well-aligned CW trace to trace the mitral prosthesis VTI. As a guide, an EOA of 2 square centimeters or more is usually normal, and below 1 suggests significant stenosis. If the numbers do not fit the clinical picture, check flow state and regurgitation, and compare with the baseline post-operative study. The Doppler velocity index is a quick, robust parameter for prosthetic mitral valves. It is the ratio of the mitral prosthesis VTI on continuous wave Doppler to the LVOT VTI on pulsed wave Doppler. Because it is a ratio, it avoids LVOT diameter measurement and is often more reliable than continuity EOA in difficult windows. A DVI above about 2.5 supports significant obstruction, while values below 2.2 are usually reassuring. Borderline values need context, especially heart rate, flow state, and the presence of significant mitral regurgitation. As always, compare with valve-specific reference values and the baseline post-operative study. Pressure half-time can support your assessment of a prosthetic mitral valve, but it should never be used alone. As a rough guide, a PHT under 130 milliseconds is usually reassuring, while values above 200 suggest significant obstruction. The limitation is that PHT is heavily influenced by left atrial and left ventricular compliance, relaxation, and heart rate. That is why the 220 over PHT formula is not valid for estimating valve area in prosthetic mitral valves. So use PHT as a consistency check alongside the mean gradient, DVI, continuity EOA, and the patient's baseline post-operative study. This table brings the prosthetic mitral Doppler parameters together in one place. The key principle is pattern recognition, not a single cutoff. If peak E velocity is 2.5 meters per second or higher, and the mean gradient is above 10, think obstruction. Support that suspicion with a small continuity EOA and a raised DVI above about 2.5. Use pressure half-time only as supportive information because it is strongly influenced by atrial compliance, as well as left ventricular diastolic properties and heart rate. Before calling stenosis, check the heart rate and flow state, and look for significant mitral regurgitation that can drive gradients. Finally, compare with valve-specific reference values and the baseline post-operative study because change over time is often decisive. Once you have measured mitral peak E velocity and mean gradient, you need to benchmark them properly. Normal values vary with prosthesis design and labeled size, so a single universal cutoff is unsafe. This table gives typical Doppler reference values for common prosthetic mitral valves across different sizes. Use it to judge whether your findings are expected for that specific valve or truly abnormal. When you see high gradients across a prosthetic valve, do not jump straight to stenosis. First, ask whether the valve could be normal but the flow is high, for example, anemia, sepsis, hyperthyroidism, pregnancy, or significant regurgitation. Next, consider a small valve or patient prosthesis mismatch, where gradients are expected to be higher for that size and model. In the aortic position, remember, pressure recovery can inflate Doppler gradients, especially in a small aortic root. Then check the basics, because misalignment or an incorrect LVOT sample site can create a false high gradient. If the pattern persists across parameters, think true obstruction from thrombus, pannus, degeneration, or endocarditis. Finally, remember the reverse trap. In low flow or severe ventricular dysfunction, significant obstruction can exist even with only modest gradients. Pressure recovery is one reason a prosthetic valve can look hemodynamically worse on Doppler than it truly is. Across the valve, the ventricle converts pressure into kinetic energy, and Doppler measures the peak pressure drop at the vena contracta. As flow expands into the ascending aorta, part of that kinetic energy is converted back into pressure. That means the net pressure drop downstream is smaller than the Doppler peak, so Doppler can overestimate gradients. This effect is greatest when the aortic root is small and when the valve effective orifice area is large relative to the aortic cross-sectional area. So if gradients are high, but DVI and EOA look appropriate for the valve, and the CW contour is not obstructive, consider pressure recovery before calling stenosis. Patient prosthesis mismatch, or PPM, is a normal aortic prosthesis that is simply too small for the patient. Gradients are high from the first postoperative study without progressive change. In the aortic position, DVI is usually preserved and acceleration time stays short. Confirm by indexing EOA to body surface area and comparing with valve-specific reference values. When gradients are high across an aortic prosthesis, start by checking peak velocity, then move straight to DVI. If DVI is preserved, around 0.30 or higher, and acceleration time is short, obstruction is unlikely. At that point, the key question is whether this is high flow or patient prosthesis mismatch. Index the EOA to body surface area and grade mismatch using the IEOA thresholds on the slide. If DVI is low, below 0.25, or acceleration time is prolonged with a rounded CW envelope, treat it as likely obstruction and escalate imaging. Small degrees of regurgitation are often normal in prosthetic valves, especially mechanical valves. You typically see a brief closing volume and small hinge leakage jets, sometimes called washing jets. These washing jets are part of the design and help reduce stasis and thrombus risk around the occluders. They are low momentum and stay close to the valve, with aliasing confined near the origin. If the jets are larger, eccentric, or associated with abnormal motion or rising gradients, think pathological regurgitation, and look carefully for paravalvular leak. This image shows physiological regurgitation through a mechanical St. Jude aortic valve. On color Doppler, there are small central washing jets directed back into the left ventricle. Pathological prosthetic regurgitation is either central through the valve or paravalvular around the sewing ring. Central regurgitation is most often linked to bioprosthetic structural failure or infection. Paravalvular leak can be seen early after surgery or TAVI, but it becomes concerning if it is new, worsening, or associated with dehiscence. Always look for rocking motion, signs of endocarditis, heart failure, or hemolysis. On this transoesophageal view, the left atrium sits very close to the probe, which gives excellent sensitivity for mitral regurgitation. You can see a regurgitant color Doppler jet entering the left atrium from the prosthetic mitral valve. Toe is particularly useful here because shadowing and reverberation can limit transthoracic views. In PSLA, color Doppler shows an eccentric, wall-hugging jet tracking along the anterior left atrial wall, which is typical of paravalvular. Grading prosthetic aortic regurgitation is difficult, so use an integrated approach. A rocking prosthesis or clear dehiscence is a major red flag and often implies severe paravalvular leak. Supportive Doppler signs include a wide jet occupying much of the LVOT and a short pressure half-time. Hollow diastolic flow reversal in the descending aorta strongly supports severe regurgitation, When feasible, confirm with quantitative measures such as regurgitant volume above 60 milliliters or regurgitant fraction above 50%. For paravalvular AR, the first step is to localize the leak using several windows. Use long axis views to see the jet direction, then confirm and map the leak in short axis with TTE or TOE. Describe the position clearly using a clock face and noting whether there are multiple jets. Severity is best supported by the vena contracta and the circumferential extent of the jet around the sewing ring. As a practical guide, less than 10% is usually mild, 10 to 29% is moderate, and 30% or more suggests severe leak. Dehiscence means the sewing ring has partially separated from the annulus. It usually presents with paravalvular regurgitation and abnormal prosthesis motion. A rocking prosthesis, especially with a new leak, should raise strong concern for endocarditis. TOE is the best test to confirm dehiscence, define its extent, and look for periannular complications. Continuous wave Doppler of a patient with a porcine mitral bioprosthesis just 5 months previously. The mean gradient was 11 millimeters of mercury with a heart rate of 51. The DVI was 4.0, with an indexed EOA of 0.48, which may mislead towards a diagnosis of obstruction. However, the pressure half-time was 120 milliseconds, which is too short to be seen in severe structural obstruction. Transoesophageal 2D image showed rocking of the mitral prosthesis, with evidence of a paravalvular gap. Color Doppler shows torrential mitral regurgitation secondary to a paravalvular leak with an eccentric jet. This was confirmed as prosthetic dehiscence during surgical correction. Think of complications as early mechanical issues versus late degenerative or chronic problems. Early complications include paravalvular leak, thrombosis or obstruction, low output, endocarditis, and occasional LVOT obstruction. Patient prosthesis mismatch is another early cause of high gradients with a normally moving valve. Later on, pannus and thromboembolism become more relevant, and bioprostheses can develop structural degeneration. Hemolysis often points to a paravalvular leak, and endocarditis can occur at any stage and may lead to dehiscence. Structural valve deterioration is the long-term failure mode of tissue valves. It reflects intrinsic leaflet damage, such as thickening, calcification, or tearing. The hemodynamic result can be stenosis, regurgitation, or both. The likelihood increases with time after implantation and may be earlier in younger patients or in chronic kidney disease. On echo, think of it when gradients rise over time and/or when new prosthetic regurgitation appears compared with baseline. When a mechanical valve obstructs, the two main culprits are thrombus and pannus. Thrombus usually presents earlier, with more sudden symptoms and often subtherapeutic anticoagulation. It is typically softer, less echogenic, and may be mobile. Pannus is a fibrous tissue ingrowth that develops later, is fixed, and is more often seen in the aortic position. Because management differs, use TOE and, when needed, cine fluoroscopy or CT to confirm the mechanism before treatment. Here, transoesophageal echo shows a mechanical mitral valve with an obstructing thrombus with restricted leaflet motion. After thrombolysis, the mass resolves and leaflet mobility improves on repeat imaging. Before treatment, Doppler demonstrates a markedly raised transmitral mean gradient consistent with hemodynamically significant obstruction. Post-thrombolysis, the mean gradient falls back towards normal, confirming relief of obstruction. When there is suspicion of prosthetic valve thrombosis, start with transthoracic echo to confirm obstruction and assess hemodynamic severity. Then use TOE to define thrombus size and mobility, and consider CT or fluoroscopy to assess leaflet motion. Next, Management is guided by valve side, symptoms, and thrombus burden. For left-sided valves, severe symptoms or a large mobile thrombus generally favors urgent surgery. If symptoms are mild and the thrombus is small, optimize anticoagulation and consider fibrinolysis in selected cases. Right-sided thrombosis is more often managed medically, with fibrinolysis if obstruction persists. When prosthetic valve dysfunction is suspected, think in patterns rather than single numbers. Thrombosis tends to be acute or subacute, with restricted leaflet motion, a mass, and rising gradients, often with a low DVI. Pannus is usually slower, with a progressive gradient rise and small dense tissue. CT can be helpful. Endocarditis is suggested by vegetations or abscess, or new paravalvular leak or dehiscence. TOE is key. Bioprosthetic degeneration progresses over years with thickening, calcification, or tears causing stenosis and/or regurgitation. And if you see rocking or an eccentric PVL jet, consider dehiscence and escalate urgently if there is new severe regurgitation or hemodynamic deterioration. This case shows a patient with a porcine mitral bioprosthesis presenting with heart failure symptoms, including exertional dyspnoea and lightheadedness. On CW Doppler, the mean gradient is 12 millimeters of mercury at a heart rate of 51, with a prolonged pressure half-time of 280 milliseconds. The DVI is 5.7 and the indexed EOA is 0.44, which together are strongly suggestive of severe prosthetic obstruction. TE confirms the mechanism, demonstrating a highly mobile echogenic mass on the anterior aspect, distinct from the prosthetic leaflets, with associated leaflet thickening and restricted motion. Color Doppler shows turbulent transmitral diastolic flow, consistent with obstruction. With suspected prosthetic valve thrombosis, the patient was started on warfarin, and follow-up TEE after 6 weeks shows complete resolution of the mass with improved hemodynamics. The key message is to keep bioprosthetic valve thrombosis in mind when gradients rise and symptoms recur, even in tissue valves. These images illustrate normally functioning prosthetic valves. On the left, we see a porcine bioprosthetic valve with thin mobile leaflets and no evidence of obstruction or abnormal thickening. The opening is symmetric and the surrounding chambers appear normal. On the right, this is a normally functioning St. Jude mechanical valve. In the parasternal long axis view, the motion of the occluder may be partially obscured by the aortic root wall, which is a common and expected limitation. Importantly, there are no features to suggest dysfunction in either case. In this example, acoustic shadowing from the prosthetic mitral valve obscures part of the left atrium. This shadowing limits visualization of the atrial side of the valve and can mask mitral regurgitation on transthoracic imaging. When image quality is limited by prosthetic artifact, alternative views or transoesophageal echocardiography should be considered. These transoesophageal echocardiographic images show a normally functioning St. Jude mechanical mitral valve. In diastole, the two hemidiscs open symmetrically, allowing unobstructed flow from the left atrium into the left ventricle. In systole, the hemidiscs close completely, forming a central coaptation line without abnormal separation. This slide illustrates common transcatheter aortic valve add-ons. At the top, schematic drawings show the structural design of balloon expandable and self-expanding TAVI prostheses. These are paired with echocardiographic images, demonstrating their typical appearance in standard views. At the bottom, video loops show normally functioning sapien and core valve TAVs. Despite different frame designs, both exhibit stable positioning, normal leaflet motion, and no evidence of abnormal regurgitation or obstruction.